Thank you very much for having me. I am delighted to talk about how research in health economics can help to improve health in sub-Saharan Africa and South Asia. So it is a well-known fact that poorer countries have poor health outcomes, and the low and middle-income countries bear the highest burden of the disease and mortality globally. And we can see this from this map, showing the rate of child mortality per country, as the low-income countries in sub-Saharan Africa and South Asia have the highest rate of child mortality, children not reaching age 5. This map shows us how much countries spend on healthcare in proportion to their available economic resources. And again, we see that the low-income countries in the same regions spend the smallest proportion of their available resources to improve health, despite the larger health needs. And as this just shows us the proportion of available resources, it underplays how much low-income countries spend on healthcare. So to put this in perspective, while we spend on average £3,000 on healthcare per person per year in the UK, the corresponding number for Malawi, a low-income country in Southern Africa, is around £40. So given that poorer countries have less resources but bigger healthcare needs, it's really important for policymakers in these countries to get the health policies right, because we know that the right policies have the power to improve population health at scale, particularly for marginal communities, because they have relatively more to gain from even low-cost investments. But the problem is that we don't know what really works at scale in low-income settings, as we have much more reliable evidence from high-income countries compared to low-income countries. And one reason for this is the lack of high-quality data covering the whole countries. So policymakers are often need to implement policies based on low-quality evidence or results from small-scale trials, which is very difficult to extrapolate to whole country settings or even anecdotal evidence. So you may think that economics is remote from the area of health, but we can use tools from economics to inform which health policies work at scale to improve population health or not, for whom, for how long, and under what circumstances, as we can transfer different ideas and tools from studying how an economic system works to how a healthcare system works, because the discipline of economics helps us to understand the behavior of various actors in different markets, for example, individuals, families, organizations, which could also be hospitals, and how these interact with each other. And we can also use the same data analytical tools to evaluate and assess big and complex data sets, which we use to evaluate economic policies to investigate the effects of health policies in the Global South. So I'll give you two examples of this from my own research. So one of the largest contributors to the overall burden of health in low-income countries stem from maternal, newborn, and child diseases. And this is due to the inadequate use of healthcare in these areas. So while many African countries provide public healthcare, which is for free, many women in rural and remote areas live too far away to access the free public health services and only have private user fee charging providers nearby. And many of these are managed by faith-based organizations, such as the one shown on the slide here. And because they charge user fees, the government of Malawi implemented a policy which asked these faith-based providers to remove user fees for these critical maternal and newborn health services in return for reimbursing them for the services afterwards. But it's difficult to know whether this kind of collaborative policy would help to improve healthcare utilization, for example, helping women to give birth in facilities rather than at home, and also improve the health outcomes of both mothers and newborns, as it is a complex policy, and the government of Malawi wasn't able to monitor the behavior of these faith-based providers, but just trusted them to provide healthcare in line with government objectives as they are perceived to work for gods. Also, it's difficult to know whether it would help women who previously give birth at home to give birth in facilities, because the policy could have only shifted the demand from public to private. And it wasn't certain whether it would improve health because of the reduced costs to patients. This could increase the volume of patients seeking care, which could lead to overcrowding and a reduction in the quality of healthcare provided. So therefore, as part of the Tanzi La Onze Global Health Partnership, together with my colleagues, Dr. Gerald Mantalu at the Ministry of Health in Malawi and Professor Martin Chokli, my colleague at the Center for Health Economics, analyzed the impacts of this policy by combining different types of large data sets. So first, we combine data on all facilities in the country, which tells us the ownership and the location and whether these facilities implemented this user fee removal policy. And then we also have access to very rich and detailed household level data for women and children, and we have information on the healthcare utilization of women. So we know whether they gave a birth at home, at a public facility, or faith-based, for example, the one shown in the picture, which we know was incorporated in this policy. And we have plenty of information on the healthcare utilization and birth outcomes, such as whether the children survived or not. So first of all, we map the location of all facilities in Malawi, and knowing when and which facilities removed user fees, we can create a treatment group for women who lived close enough to the user fee removing facilities, as we also know the location of the residence of the women in the household data. We can also then use statistical techniques to compare the birth outcomes for women in the treatment group compared to the control group because they live too far away, and look at the effect of healthcare utilization and birth outcomes before the policy was available compared to after the policy was available. And our analysis shows that the policy reduced home births and increased the uptake of faith-based facility services of around 20% for certain populations. And we also find that it did reduce the risk of infant mortality by around 18% for some populations. And we also find that the women most in need, those who were previously facing financial healthcare barriers to access healthcare, experienced even larger improvements. But the problem is that some of these effects were short-lived, and this may be due to a delay in the government reimbursing the facilities, and suggests that sustainable healthcare financing is really key. But on the whole, it looks like it's a good idea for governments to collaborate with faith-based facilities rather than building their own hospitals in these areas. But we may not recommend governments to collaborate with faith-based facilities for all types of service areas, as our other research shows that they're not as good in delivering sexual and reproductive health care compared to public providers. And this really illustrates the importance of understanding provider behavior in the very different healthcare markets in low-income countries, because we have very little evidence for these. Another major contributor to the burden of ill health in developing countries comes from malnutrition. And malnutrition doesn't only mean being too thin or too short, but also includes the inadequate intake of minerals and vitamins. And the mineral iodine and the deficiency in iodine is the largest global cause of reduced cognition. And therefore, over 140 countries have implemented iodine fortification policies, which ask salt producers to add iodine to table salt. And there's been plenty of small-scale randomized controlled trials showing positive effects of on cognition stemming from supplementation of iodine. Because iodine is needed during critical time periods for brain development to enhance cognition, and too little iodine intake during these critical time periods in early life, including gestation, will permanently reduce cognition throughout one's lifespan. But it's difficult to know whether a blanket fortification of salt with iodine would actually reach deprived children in need in low and middle income countries, as there are overall high rates of malnutrition. So therefore, during my PhD, I evaluated whether the universal salt iodization policy in India improved children's cognition in tangible ways, which really matters for economic development, such as learning outcomes, as these are very low in many middle and low-income countries. So this picture shows the advertisement of a common salt brand in India, and this child looks rather affluent and probably has good access to overall nutrition, but it wasn't certain that the low-income children, the poorer children in rural areas in India would benefit from this policy, as India is home to some of the highest rates of overall severe malnutrition and also have many areas that provide low schooling quality. Also, the salt market in India has a high proportion of small-scale salt producers, and iodine fortification is very costly for them, so they might not have the incentives to adhere to the policy. At the same time, it's very difficult to monitor that the salt is adequately iodized because iodized and non-iodized salt look exactly the same. So therefore, I first investigated whether this policy increased the consumption of iodized salt. So I combined different data sets across time, representative for all of rural India, which provides data that tested the content of salt, of the iodine content chemically, so it's reliable data. And we can see that the policy led to an increase in the consumption of iodized salt after its implementation in 2006. But we also see high coverage before the policy because different states had their own policies in place prior to the universal nationwide policy was implemented. To understand whether this policy improved learning outcomes, to define a treatment group that would benefit from added iodine, I had to rely on information which tells us which populations are at risk for iodine deficiency. And because no current nationwide data is available for all of India today, I had to rely on historical data on goiter levels from over 100 years ago. So I geocoded this map shown here, which tells us areas with high rates of goiter. So goiter is the enlargement of the thyroid gland due to iodine-deficient food and iodine deficiency in the soil it's grown on. And these ecological and geographical factors for iodine deficiency are likely to remain today. And then I combined this historical data with current data on over 700,000 rural children and their test scores in numeracy and literacy. And knowing where they live, we know who is more likely to benefit from the policy because they're at risk for iodine deficiency. And knowing when they were born, we know whether they were exposed to the policy during critical time periods for brain development. So after many statistical analyses, I find that the policy improved basic numeracy and literacy skills by around 2 to 4%. And some interesting findings stand out. First of all, children who lived in states that have many salt producers experience a higher cognitive or learning improvement because they also experience a higher consumption of iodized salt compared to baseline because the salt producers could previously lobby against the implementation of state-wise policies prior to the universal nationwide policy was in place. Second, more deprived children, poor children and girls benefited even more and improved their reading outcomes, especially at more difficult levels of reading, even more. So we learn again that we need to understand the behavior of different actors incorporated in government health policies, but also that nutrition policies, which are very different from schooling interventions, can help to unlock children's potential for a bright future. So it's very important that us economics or health economics researchers collaborate with local policymakers, local researchers in the countries that we are studying, and also researchers across disciplines. In this way, we can really create a sustainable global impact. And at York, we're doing this in alignment with the value of being a university for public good by engaging in collaborative large global health partnership. One example was the Tanzila project, of which the maternal healthcare research was a part of. And currently, I am engaged and contributed to large global health partnerships, which is trying to help prevent the emerging challenges facing South Asia and Sub-Saharan Africa. So the top photo shows my colleagues from the Tanzila project, and this project is trying to build a large health system data model which we can use to assess the future impact of various healthcare interventions. The bottom picture shows my colleagues from the Center for Impact project, which is looking into curbing the cardiovascular diseases, which are rapidly increasing in South Asia. And we started doing research into the determinants of the rising obesity rates in Pakistan. So the coexistence of both obesity in Pakistan and other countries undergoing an economic transformation and malnutrition at the same time really highlights the complex but also dynamic nature of global health and health policy in these countries, which also magnifies the need for further rigorous research in this area. Thank you.